And we're good to go when you are.
All right, sounds good. Thanks, Tom.
What's that?
Welcome back, everybody. The charts I pulled, I decided to do a couple traumas. Of course, traumas are interesting because they can go in any direction. Usually in Worcester direction, but yeah. We'll play on words there. Yeah, and then we'll talk. We have a couple seizure patients here, which are so we are going to put the didactics with the chart review, and then if you guys have any interesting case you want to talk about or questions at the end, I'm here for you. So that's what I like to do. So this one, a lot of people probably already know about because we don't get these kind of cases very often. And when they do, of course, a little town like this, word gets around. So the crew brings in a 31-year-old male. I wasn't on this. I don't know where I was, but this response to the scene was a gunshot wound. Sound familiar? Yeah. The patient was drinking heavily. Drinking heavily, as reported by a friend on the scene. He was playing around with a firearm when it discharged, and the bullet came through the mouth, exited through the top of the right head behind the ear. Earline and brain matter was herniating out of the exit wound with bleeding, and you can only imagine what the GCS is here. Blood pressure is 147/78, and interesting enough, I don't think the blood pressure changed. Yeah, he was pretty stable throughout that's the thing, which is kind of good. SpO2 is measured at 98. He was mechanically assisted with DBM 22. This was all at the beginning. His end title's 29. His heart rate's 49. What's that tell you? Bradycardia? Yeah, brain injury. So brain injured patients often are bradycardic. So keep that in mind. They can be bradycardic and normotensive or hypotensive, right? So usually that's a good clue if something's going on. So I'll share the narrative with you, and then we'll go back and look at interventions. And in reviewing this case, I didn't see any glaring bad things here. The only bad thing I saw was the patient's condition, unfortunately. So the history is obtained from a witness or friend or somebody on the scene. Patients playing around with a loaded firearm and unfortunately paid the price. If the way the patient looks, found sitting back on the living room couch, he is unresponsive. That tells you he was seated when he was doing this, which could be important. He's breathing on his own, strong radial pulse, skin warm pink, non-diaphoretic, and to traumatic head injury as previously described. So how long was the wound between the time the wound was inflicted and the paramedic got there? Just by the description, probably just a matter of minutes, right? Because the patient has no diaphoresis, he's warm, he's pink, he's got fairly decent vital signs except his heart rate's slow. So that tells you that it's just recent. Obviously, the longer he lays there with a wound like this, the worse it's going to go. Okay? This is important. He's breathing adequately with occasional mild gurgling of blood. His pupils are non-reactive, unequal with the left being dilated. The gunshot wound is through the right and the left is dilated. Does the patient have brain injury? Pretty easy answer. It's obviously a brain injury by the wound. But if he had a big hoodie on, his friend wanted to cover the wound because his friend gets sick. His friend covers the head wound, and you don't see that right away. You could tell something was wrong. Okay. Let's see. About 250 cc's of blood on the clothes, the couch, and the floor. If you were Dexter, you could figure out the trajectory of the bullet and the blood spatter and all that. Okay. This is important in your run sheet, and I appreciate the author writing this in the run sheet. PB secured the scene and applied pressure with trauma dressing prior to EMS arrival. So that sentence tells you that the scene is safe, scene is secured, and it gives you an idea of what the patient looked like. on arrival. It's a really good description. Holds up in court because, you know, if ever there was a lawsuit, one of the questions the plaintiff attorney may ask you is, was the scene safe? Did you violate a crime scene by taking care of this patient? And the answer was a resounding no, because the author had dictated that in the narrative. Kind of a nice side note there. He describes the exit as approximately 3 centimeters of brain matter present outside of the skull. No other injuries are noted, which implies that you looked over the patient and did your primary survey. Patient extremity is lifted to stair chair for extrication from the home. Made a request for life flight. At the end of the narrative, it looks like it was a ground transport. Life flight couldn't fly, I'm assuming.
They had an extended takeoff time for some reason.
Oh, okay. Yeah. Yeah.
I think one was busy and the other one
Time
was in the
matters,
hangar,
yeah.
not outside.
Because this hands down should be an airlift, but that doesn't always happen. Yeah. Okay. Again, you make note that the scene is safe. Additional resources are on scene if asked for. Pressure is held over the wound. So obviously the patient is still exsanguinated. Is there a possibility if the patient is going into shock? He's not only there, even though you've got a normal blood pressure, right? Okay, don't be fooled, because what you see is later on what you may get. So you may get hypovolemic shock. Always be ready. You guys obviously don't carry blood, but if this is going, well, it is going to a trauma center, you can bet they'll have at least 2, if not 4 units of O-neg blood ready to go when the patient arrives. Let's see. You guys don't mind me going over this line by line and pointing out the good and the bad and the ugly? So far, no ugly. Patient is intubated here due to concerns over compromised airway. Good choice, because your GCS is so low, you obviously have trauma to the brain. Is this patient going to support his airway on his own? Loud, resounding no. Okay, initially he is. You know, he's got some respirations there, but it's going to deteriorate, no question. And the author makes mention of that. Respiratory rate around 20, give or take, 7.5 EP tube, 26 the lip. Visualized. And the author notes why I know the ET tube is in the right place. Don't forget in your documentation to document why you know that tube is there. Lung sounds bilaterally are equal. End tidal CO2 is appropriate. Fog in the airway. No air over the stomach. I mean, there's all kinds of little things to document. It's really, really good. As you mentioned, end tidal CO2, misting in the tube, the auscultation of the lungs, auscultated by your partner, lung sounds equal. So that's really good. Patients supported by BVM, 15-layer non-rebreathe. Of course, that's what you do. 12 lead is done. Why didn't you do a 12 lead at the beginning? Because airway bleeds first. Right. Why would you be so silly as to do an EKG first while the wound's bleeding or hurting or whatever? Oh, I want to know. So good form. The patient remains normotensive. Finger stick at this time is elevated. That's recorded elsewhere in the data. Another IV start. Looks like with at least 2, if not 3 IVs. Okay.
The airway. Hold it.
Yeah, you definitely, 2 IVs. Yeah. Most of the time we like two accesses on a trauma patient. If one's an IO, one's an IV, that's fine. If you have 2 IOs, that's fine. 1 normal saline infusion, that is awesome. Patient stripped and assessed for secondary injuries with none noted. What a great sentence if this ever went to court. Again, did you ever think to look for pelvic trauma? Because my patient exsanguinated in the emergency department and died, and one of the ED techs happened to mention, oh, I think they had a broken pelvis. And so the plaintiff attorney will be attacking us thinking that they died from exsanguination of the pelvis rather than bullet wound to the head, which is a stupid example, but you know how lawyers can be. And this sentence in here protects they defended because you did the secondary assessment right there in black and white. Kudos. Warm blanket patient on patient, warm fluids. Can a trauma patient become hypothermic? Resounding yes. Can it happen quickly? Yes. Have we always seen, we've all seen that. Yeah, it's terrible. So the warmer they are, the better they perfuse. And the cooler they are, the less they perfuse, and they can go into shock really easy. And again, notes vital signs are stable. Patients a little hypertensive, 140/80. SATs are 100. M titles 32 to 35. Respirations are 22. Why do you think the treating paramedic is hyperventilating all of that? Is that appropriate?
Actually, the patient should type of ventilate.
The patient was breathing for you? Okay. Well, that brings up a good point. Hyperventilation is good in a brain injured patient, right? So that's what we want. It prevents acidosis and it improves oxygenation and perfusion to the brain. So he's brought to the ambulance and you take him to UMass. Now, I was able to get into Epic. Do you know what the outcome was?
The uncle was at the bedside by that evening. The father flew up from Florida and was there the very next day. They made him an organ donor, and they actually harvested quite a bit.
Good. It's not good for the patient.
Good brother.
That's awesome. He saved a lot of lives. Only 31. Yeah. Moral of the story is don't play with loaded guns. Any of you that are in the room that are gun owners know that. I don't want to be too preachy on whole Second Amendment and gun rights and stuff, but from a family of hunters, of course, a lot of respect for firearms. Firearms are great. They're a lot of fun. They're important for sport and recreation, but just like everything else in life, they have to be handled very, very carefully. Just like money. Money's a great thing, but it's not handled in trouble. Any questions on a trauma case? Good documentation, Mark. I appreciate
That
it.
was Cole.
Cole wrote that? Oh, okay. So you were busy doing that.
By the time we got back, I was up here.
Yeah, okay. Cole did it. Good job. So bottom line, you guys, when you go back and do your documentation on a case, those are things to think for. All right, case number 2. This is a 25-year-old female. She's involved in a 2-car motor vehicle accident. And here's the narrative. I like a good story. And it takes up about a third of the page that tells you something. Okay? It's 21:36, so this is in the evening. You're dispatched to the roadside. This is Route 140, which never sees car accident. Updated on route that you had one party unresponsive with a pulse. You get there and they're just seeing a large debris field, and one truck with the front end damage, pretty severe, perpendicular to the roadway. The car is in the right lane of the roadway with passenger side of the car, 24 inches of intrusion into the passenger compartment in the area of the A-pillar through the C-pillar. Can you imagine? I mean, that amount of impact. Incredible. Yeah, just reading this, it's like mind blowing. I'm really surprised this patient is even alive at this point. Barely alive, as we'll see. That's a huge impact. So we have truck hitting small car loses, and obviously there was a lot of speed involved. Airbag deployment was noted, so that tells you it had to be above 35 miles an hour for the car, right? Because airbags are usually around 35 miles an hour before they're engaged, unless that's changed. The monitor was unable to be applied due to positioning and intrusion in the passenger compartment. Good to note what your position and your patient looks like. On the last case, the patient was on a sofa, on a couch, clothed. The patient is in the driver's area, but unable to really get into the patient. It gives you an idea. It would be different if the patient were actually not in the vehicle and maybe 250 feet away from the car. And that would tell you maybe she was ejected, or did she get up and then just pass out? So it's good to know. Good description of the scene, good description of the patient. Remainder of physical assessment unable to be performed due to limited space and mobility. If we don't do something in medicine, we can document that too. There's lots of reasons I may not do a rectal exam on a patient with GI bleeding and rectal bleeding, and I have to document why. And if I've got my rear end covered with good documentation, I'm fine. Can't open the doors and extrication is initiated. That tells you something. Driver of the other car briefly assessed by EMT on scene prior to additional ambulance with no gross life-threatening injuries requiring immediate attention. Great. That patient's agreeing. So that patient can just kind of wait. Through a walkie-talkie. PD is on scene, unable to assess pulse and confirmed no heart sounds on auscultation. Now, one would assume that when that sentence was written, that the implication was the police were probably first on the scene and secured the scene for safety. Now, just a hint, maybe PD had secured the scene and determined that they were unable to, you know what I mean? Unable to assess the pulse and so forth. Not just a very minor point. Initial arrest at approximately 21:47. Aha. CPR is initiated for previously broken window of the car. That window is gone. Patient extricated to the stretcher and then ambulance. Trauma assessment. Yield large avulsion to the middle of the patient right anterolateral thigh. So it starts right about here, scanning down past the knee to the posterior upper calf. Wow, can you visualize that? Yeah, any bleeding, you think? I bet there was, and I bet the patient is unstable in that regard. Left leg is atraumatic. Pelvis is stable, no incontinence or discharge noted. Abdomen soft, non-distended with rigidity in upper quadrant. Rigidity after a car accident. What do you think? Yep, that's blood in there. Blood until proven otherwise. Could be a liver lac or a splenic lac or both, for sure. Could she have perforated a valve? Yep. Could it be an aortic bleed? That's always possible. Chest wall unstable across all fields. Now what are you worried about? A flail. That's right. Are you thinking maybe she'll need chest tubes if we get her resuscitated? It's a good possibility. Crepitus to sternum. What's that tell? Crunchy sternum. Did she hit her breastbone on the steering column? I bet she did. So not only does she have a broken sternum, perhaps, but she has broken ribs and a flailed chest. Do flailed chests ventilate very well? Absolutely not. Does that set the stage for maybe a hemothorax or pneumothorax? Absolutely. Could she have a myocardial contusion, pericardial hematoma? Could she have a lacerated coronary artery? Yeah, you name it. So all thoughts are across the board. So your differential is really wide here. Obviously, you don't have to list all that, but it's just fun to think about. Upper extremities atraumatic. She does have a 2-centimeter laceration to her right hand. Shoulders, collarbone stable. No JVD, no tracheal deviation. No tracheal deviation. What's that tell the reader? Is there a tension? More than likely not. Yeah, that's good. Crepitus to mandible with left side free floating. What happened? Did she break her jaw? Good possibility. Got free floating jaw here with a lot of crepitus. That's a good possibility. Crepitus to mandible, full thickness laceration from the left corner of the jaw to the left ear. So she's got laceration just like this. Wow, that tells you something too. Are you worried at this point about maybe some facial fractures? You already got one. How about the face? Well, the writer goes on to tell us that there's a unilateral Laporte 1 to the left side. So that means she's got her orbit. Laporte 1 is here. Laporte 2 is this triangle here. Sorry, viewers. And then Laporte 3 is total dissociation of the face from the skull. Just for review purposes. Any Laporte fracture needs to go to trauma center. Orbital fracture with left with swelling. She has a depression in examination. What does a depressed orbital fracture do to the muscles that control your eye movement? Right. Yeah, the muscles, the inferior and superior rectus, the lateral and the medial rectus, which are the four muscles that control your eyes, they're surrounded and in the orbit. So if the orbit gets depressed, it pushes in on the muscle, and this allows the muscle to move the eye. So sometimes with eye exam, if you do have a suspected blowout fracture, if the eye gaze is downward and you ask them to look up, the one eye looks up but the other eye doesn't, you can really be highly suspicious they've got entrapment. Just a clinical clue. Same way with any of the movements. So you got four cardinal movements of the eye, right? You have right to left horizontally and up and down vertically. Those are your four cardinal movements. If you're missing one of those movements, you got trouble. All right, I diverted again. Temporal and parietal are stable. She has a right occipital deformity with swelling and possible open skull fracture. This poor lady's in the mouth. Blood from left ear with negative halo. Remember, we have jaw injury, we have a laceration, and we have at least a report 1 here. It's not surprising that she has blood out the ear, because if the sinus is damaged, what is right adjacent to the sinus back in here? The ear canal, right? So if I went straight back through my maxillary sinus, right back this way, I'm going to come right into the middle ear. So blood from the sinus is probably leaking out that way. It's all anatomy is a lot of fun. And all of you want to go back and take an anatomy class, right? That's what I thought. C-call are not applied, and why? Facial fractures and risk of further injury. Good point. Yeah, I think you got to weigh benefit versus risk. I think the risk of a stiff collar in this case would be higher than the benefit. And you already know she's probably board bound just based on what you know so far. Airway suction, when she was found, direct laryngoscopy attempted with the Miller 3, but abandoned due to the severity of maxillofacial trauma and no view. That's good. I tried, but I couldn't, and this is why. Good. SGL not attempted with lack of bony prominences of face. NRB is applied at 15 liters and airway frequently suction. Recess efforts included initiated upon expectation and continued for duration. CPR was initiated by PD in the car, and HQ CPR continued by Lucas. Lucas attempted, but due to injuries, they couldn't get a good seal. And that's because she's got crepitus over the sternum, possible flail chest. There's not good suction there, Lucas wouldn't work. IO to left tibia, good marrow return, good flow. That's good. We know the IO works. Leader saline to pressure bag at IO site. And now we get to the patient found in asystole, and that explains the CPR, which I already assumed the patient was in dire straits because of the description I'm reading already. Is it important that your narrative be absolutely perfect in the order of events? No, not necessarily. Try to tell a story in the flow, but as you know in medicine, sometimes we'll do part B before we'll do part A. It's very common. And in what we do in emergency medicine, we treat, then we diagnose, right? So we treat what we see, we treat the seizure, then we step back and say, why the seizure happened? Do they have pre-existing seizure, or are they overdosing? Okay, so she goes from asystole, we give her what drug? Epi, right? Nothing happened. We do the 2-minute first check, we get PEA. So what drug do we give? Epi again, that's right. Third check, she's PEA again, we give another dose of Epi. Any other drugs you want to consider if it's PEA? H's and the T's. She might be hypothermic. I don't know what the temperature was. And she's obviously hypovolemic, right? Could she be hypokalemia, and are you going to worry about it and do anything about it? No. Gag me again. Why are you bringing it up? How about low blood sugar? I think with a stopped heart and no breathing, sugar is kind of down on your list of worries. Well, I stopped CPR so I could give her some dextrose. Yeah. So airways attempted as noted, you can't manage it, but you're doing the best you can. She's transferred to a bed. All signs are looking like she's not going to make it. I think I wrote this down. Yes. She got to Haywood. Resuscitation efforts were continued, what looks like for about 10, 15 minutes. By this time, resus time had been a little over 30 minutes. You and I both know the mortality rate of code or trauma codes is really high, right? Now, just from the description of the injuries, you all knew this patient was more about, right? It's not hard to tell. So scene time was around 21:35, 40, it looks like, and she expired at 22:08. So what that tells me is that the crews worked very fast to do all they could on the scene to get to the patient. Obviously, this patient had to go to Haywood, hands down. She's cardiac arrest, trauma arrest, and you have to go. So, and it's unfortunate that that happened, but most people, even family members and laymen, would understand this is just too bad of an accident. Yeah. Any questions on the case? Overall, I think the review is good. In reviewing this, like I said, little minor glitches here and there. Well documented. Okay. Now a couple seizures for you, and then we can call it a night, if that's okay. This is an 89-year-old, so already a gold star on the radar. This is a geriatric patient who is picked up for unresponsive, and in the chief complaint, the writer puts trismus, which I thought was that's really helpful because that kind of gears you in as to what may be going on. Also, in the initial page here, it says that she's DNR. DNI has most fun. How convenient. I kind of like it when you guys get called to a scene and everything's in order. You know exactly where we go with this patient. So here we are. We're responding to this 89-year-old, unresponsive. She's found in the right lateral recumbent position on the floor in care of the police department. PD states they arrived to call for an unconscious patient, usually PD's first responders, and they found her face down on the floor with head on pillow with agonal breathing. Okay, so that's a little bit different than what you're seeing, right? Which implies the police probably repositioned her. And why did they do that? To open up her airway. So I think that's appropriate. First responder action is to log roll the patient in a good manner to get her away from face on pillow, lying on her side, so she's got a good airway. Plus the agonal breathing, it doesn't sound good. They rolled the patient and the police tells them this. Patient's respiratory drive increased by changing position. PD states that patient had oral secretions and nasal secretions pulled on the floor where patient was lying. Okay. By the way, I forgot to mention in the didactic portion, can seizure patients drool or demonstrate fluid, or can they vomit, or can there be secretions from the airway? Absolutely. So they may have rhinorrhea, they may have drooling, they may have vomiting. So keep in mind airway protection there. They state that her last unknown time well is unknown. So we don't know how long she's been on the floor. She was not known to be ill, according to staff. So this sounds like she was picked up in a group home somewhere. But she had been evaluated at the hospital recently for new onset seizure. What a wonderful piece of history. So that narrows down some things. Now we know she's had a pre-existing seizure. Patients who've had a seizure in the past are that much more prone to a seizure in the future, right? Just like with a lot of other things. If I've had an asthma attack in the past, I can have one again. Patient shows some trauma to the left superior periorbital area up in here with noted abrasion and a question, contusion versus pressure injury. Was she on the floor and then this is floor pressure, or did she hit her head on the floor? But they said there was a pillow there. So I don't know. You be the judge of that. Patient is noted to have no response to painful stimuli. Where does that put her GCS vibes? It's just eye-opening. It's assumed to be negative there because they mentioned they had to open her eyes and her pupils are constricted at 2 millimeters. So no eye opening, no response, she's just lying on the floor and she agonal breathing. Yeah, so it sounds like she might be heading for an airway, right? Okay. Pupils are constricted. Negative nystagmus noted. That's a very helpful sentence that ruled out, because with nystagmus, that often could be vertigo. That's causing her to collapse like this. Could be syncope with vertigo. Could be a neurological event such as a brain bleed. No gross tremor or seizure activity. Very good to know. Patient is noted to have trismus with a portion of the tongue in between the teeth with dried blood noted. Visible portion of the tongue is purple in color. Isn't that a great couple sentences? You can visualize that, right? She's got this. And if it's purple, how long has it been there? More than 5 minutes, probably, right? So what's that tell you? I've got blood, a tongue that's trapped in between a tight jaw that's purple. Is she having a seizure? Yeah, absolutely. Is it a tonic-clonic seizure? Nope, because the author here, says that no seizure activity was seen, so she's not jerking or clonic or anything, but the writer notes that she's got this tongue out and trismus, and she's got a history of seizures. Good writing. So that narrows down what we need to do, right? So this kind of narrows it down to, oh, this is what we do. Face is intact with no deformity or crepitus. The neck and the back are without deformity. IV is started. Normal saline. Blood sugar is taken. It's 163. Does she need glucose? Is the answer. So that rules out hypoglycemic seizure. Staff provides EMS with most order. For the patient, indicating that she does not want intubation or resuscitation. So now with a GCS of 3 or so, am I going to tube her? And the answer is no. Am I justified? Yes, because you've got a Volz form that says no. She is transferred to the ambulance hot. Her airway is being supported with DVM. 10-liter downward breather. End title is noted non-bronchospastic waveform. That's very well written. Secured for transport. Continued trismus noted. Inability to suction. Held using an NPA for fear of gag reflex. Good point. Nasal trumpet could have been used. That's probably a good idea. I probably didn't think about it at the time. I have to confess, I often don't. My texts think of airway stuff like that better than I do. Yeah. So, okay. Occasional unifocal PVCs, 12-lead non-diagnostic for ischemia. Now, the patient is given a drug called midazolam, drug of choice. And why? Because of all the description I gave you. This patient was having a seizure. 2 milligrams didn't work. Another 2 is given. No major changes in there. Saline is started. The paramedic applies medial pressure to the area behind the patient's earlobe, and with subsequent temporary release of the trismus, the EMS is able to hold the mandible with jaw thrust. Isn't that great? Basic airway support. I love it. While the OP is placed to protect the tongue, so now the tongue is free, the airway is better, and the patient has deep impressions of teeth on the distal tongue. No gross secretions, no active bleeding. Gets to the hospital. She's seen by the night doc there. The trismus and twitching, unfortunately, continued in the emergency department. The patient was given another benzodiazepine at this point, 2 milligrams of Ativan, 2 milligrams of Ativan, 2 milligrams of Ativan for a total of 6, going nowhere. This kind of goes along the lines of this we're talking about. So the next step was a load of Keppra. Keppra is an anti-epileptic we've had for years, which it covers a lot of variety of seizures, all the seizures we talked about tonight. Keppra seemed to work, but the patient was in a deep post-ictal state. Lactate 5.1, is she in acidotic state? Yep. Why do you think she had a lactate that was elevated? Go back to the scene. What? Seizure? Yes. Number 2, she was, yeah, she was on the floor. This could be rhabdomyolysis, right? Her downtime's on now. So maybe her CK is 20,000. Actually, it's normal, but you know, so she could be really acidotic and rhabdo. Could be a metabolic acidosis too. Her bicarb was only 17, and her anion gap was elevated at 24. So this is a gap acidosis. And potassium was 5.1. And she had a white count of 16. So that's elevated. The white count can go up if there's inflammation or insult to the body, or if there's infection. She's 89. 89-year-old on the floor. History seizures just recently in the hospital. 16 count, lactate up. Is she septic? My first go-to, septic to fluid. Otherwise, I'm going to flood this lady with fluid, get broad spectrum antibiotics on board after I do blood culture. That's where I would go, in addition to treating her with Keppra. And that's exactly what happened. Inpatient, I really couldn't find a good inpatient chart on her. My computer was acting weird, so I don't know where she went from there. So cool case, huh? This is one of those unresponsive and trismus. I think that's cool. I don't know who called in a trismus, but that was put in the report. So already the responder is thinking maybe this is a seizure. All right, any questions on the case? You're pretty good. Time for one more?
You got like 20 minutes.
Yeah,
That's
okay,
cool.
that's cool. Okay, this one kind of the same. All right. This is a 54-year-old biological male. He's a transgender patient, a female. You get called for, and this makes your diagnosis easy, tonic-clonic seizure activity with the quarterback posture. So it makes your diagnosis easy because now you're on the central nervous system. You've got to start thinking what caused the seizure in the first place. So here you go to a private residence. He's actively seizing, struck his head. He has a history of epilepsy. Remember, epilepsy by definition, I've had 2 or more seizures in my lifetime, so yeah, I'm a seizure patient. Is there a chance that this patient is on a medication or 2 for his seizures? Yep. So that's an important piece down the road here when you guys do his history, get a medication history. Is it all right to do a grab bag and bring it to the hospital? Certainly. We do it a lot, which is very, very helpful. So mother heard, and this patient's 54, mother heard patient fall from standing in the next room, found him on the floor in the hallway having a tonic-clonic seizure. So there right there, it tells you he's not been on the floor very long at all. Mother thought patient was, quote, coming out of it after a few minutes, end quote, but continued to seize. That's why the 911 call. Upon arrival, 54-year-old on the floor, tonic-clonic seizure activity, decortical posturing. Doesn't sound good. Mother does not know when the last seizure was, and she thinks that he's been compliant with medication. Good question to ask. Is Junior here actually taking his Dilantin trileptos Keppra? I think so. Another question I asked right behind that: are they taking any recreational drugs or marijuana? And are they drinking? Sorry, ma'am, not to offend you, but these drugs and alcohol can actually decrease seizure threshold. And the medicine that works when your threshold is here doesn't work when your threshold is here. So you can explain it that way. Alcohol can cause a seizure, but it more often than not drops your seizure threshold. No recent illness, cold, fever. He was complaining of feeling very dizzy right before he fell to the hardwood floor. So could it be syncope? Very not likely, because I'm actually seeing them seize here, and it's been happening for more than 2 minutes. Myoclonic jerking from syncope doesn't last that long. So I'm giving 2 milligrams of midazolam IM, left deltoid, very appropriate. Seizure activity appeared to have stopped 30 seconds to a minute. Blood sugar is 91. Normal or abnormal? Normal sugar, yeah, you wouldn't have to give them this quick. No deformities in step-offs felt on palpation of head, neck, and spine. Patient did not. Oh, I just got that. There's a little subtle joke there. No step-off deformities on palpation of the head. I don't know if you can have a step-off deformity up there, but I get what he's right. Did not appear to be incontinent. That's a good thing. There are tonic-clonic or generalized seizures that cause incontinence. Tongue biting and incontinence, that's a seizure. That's not syncope. So when you guys document that, whether or not they had it, that's very helpful for the reader, to know what you're dealing with. CSM in all extremities, mother removed hearing aids to leave at home. So that's nice to know. He's got some hearing impairment, which may be contributing to all of this. Not likely, but good to know. Ears clear, no fluid or blood present. Attempted to measure and place C-collar, unsuccessful. Placed the towel roll around the neck, secured. Good job. Patient removed from the house with negative retract device. On stretcher, secured. X semi-fowlers without change. Transfer looks like it's been stable. Now en route, spontaneously opening eyes, but not tracking or making eye contact. Remember, I told you as they come out, post-ictal phase, they'll be confused, unaware, weirdness, neurological weirdness. So you're documenting what you see. I think that's great. That even further clinches the diagnosis of a seizure. This is a post-ictal period. Patient remaining unresponsive to all stimuli, transferred to the ER on a board. Good job. We probably got them off the board once we done. Sometimes you guys know, I'm preaching to the choir, you need a board for transport. Okay, here we go. CMED's been notified. On arrival, guess what happened? Seizure again. Tonic-clonic activity noted in right hand and both legs. So right hand, both legs. Is that a generalized seizure? Not by definition. Generalized is everywhere. Now it says it's right hand and both legs. That's more focal. So this is interesting. Could this patient be a complex seizure patient? And I would say it was on yes. Because the seizure that you saw in the home was tonic-clonic. The seizure that you and the provider and the nurses are seeing in the department is more focal, one-sided. Isn't that weird? Can patients have more than one seizure focus in the brain? Absolutely. So we gave them 2 milligrams of midazolam and the seizure stopped. We found out that this patient was on Trileptal. His levels were low. Question mark, was it non-compliance or was his body just demanding more Trileptal? We don't know. He was started on Keppra right after the midazolam. Admitted, did very well. His Trileptal was adjusted, discharged home. Drug screen was negative, alcohol was negative. His electrolytes were all balanced. So in other words, all that other stuff I told you that can cause seizures didn't. So it was just Trileptal. Pretty cool. So long story short, seizures come in different colors. They can be focal, they can be generalized, they can occur when the patient's awake, with lights are on, or not, and the person's not home. Seizures are almost always treated, with rare exception, with midazolam or benzodiazepine. The exception to the rule is an eclamptic seizure in a pregnant patient. That's magnesium sulfate. Also, if you elected to give magnesium to an alcoholic seizure patient, you can do so. I think that would be a MedCon call. Yeah, I'd have to look it up. But when in doubt, call. We're always on the radio. Well, we always try to get on the radio. Get to you. So. A pleasure, a joy. I always like teaching. Do you guys have any questions? Thank you for attending. That's great. Yeah, make sure you sign your sheets and both sheets for both hours. I really appreciate your time and attendance. Great.
Thank you.
You're welcome. My pleasure.
Everybody's saying thank you online. Just so you know. He's not here.